Afternoon again, and again, this is part two, and we will be continuing with last week's presentation. Last week, we covered thrombophilia with the exception of lupus. We went halfway through lupus approximately. Today, we'll finish the other half of lupus, completion, and then we will go into factors. For factors, we'll speak about factor assays, of course, a bit of technicalities, and the commercial and the competition aspects, and that will be it for today. So for lupus, last week, we spoke about some technicalities about how does lupus work. Just a quick reminder, because this is quite relevant for the rest of the presentation. We said coagulation factors usually have to sit on the surface of negatively charged phospholipids to do their work. So if they cannot do this, if they cannot sit on the surface of negatively charged phospholipids, they cannot do their work. Coagulation is delayed or doesn't happen. So this means prolongation in your clotting time or no clotting at all. So what can interfere with this process? As we said, if you have lupus anticoagulant antibodies, they will sit in the place of coagulation factors on the surface of negatively charged phospholipids, which means lupus will cause a prolongation in the clotting assay or in the clotting time. Okay, so this is a quick review. And we stopped at this slide last time. The importance of this slide was to highlight, we said, if we have 1,000 patients, 100 patients, 500 patients, etc., if we only use APTT-based lupus testing, we will never be able to detect all of them. If we only use DRVV-based lupus testing, we will never detect all of them. That's why all the current recommendations, all the current bodies that advise on lupus testing, they say you should ideally use two methodologies to detect lupus patients. And the most recommended ones are APTT with silica activator. So for example, this is the case of our PTTLA and our staclot-LA. The activator is silica. And the second type of assay will be DRVV-based assays. We discussed those last time. I will not repeat them again here. So the point is, the user should ideally use both assays. Yes, it's costly. I understand that. Yes, it's more work. I understand that. But you don't run the risk of missing lupus patients. Okay. Why would some reagents miss lupus patients? That has to do with the nature of lupus anticoagulants and has to do with the nature of the assay itself. This is not something under the control of any manufacturer because more or less it's biology. Okay. Now, continuing with the presentation. Now, we said there is a misunderstanding generally with lupus, and it's a very common misunderstanding where users would just use the screening assays to say the sample is lupus positive, and this is a huge mistake. And the other less common mistake is that users, when the confirm assay becomes prolonged, that's the time they say, oh, confirm assay is prolonged, this means the sample is lupus positive, which is incorrect. It's an incorrect understanding. Why is that exactly? I will explain the way screen reagents and confirmatory reagents work, because this is very important for you when you're communicating with the customer or when you're offering them new assays. Because they might tell you, for example, why are you offering me confirm? Why would I buy it from you? It's extra cost. Why are you wasting my money? I'm just using the screen, it's doing the job. That's absolutely not correct. Now, the screening reagents, what exactly do they do, or how do they exactly work? Screening reagents, from the name, their only point is to tell you this sample may have lupus or may not have lupus. If it may not have lupus, we stop testing. Lupus is excluded. If maybe we have lupus, we have to run the confirm test. The name says confirm, okay? So screening reagents can never tell you lupus for sure. Only confirm reagents can do that. So screen reagents, they only differ from confirmed reagents in one simple aspect. This aspect is the amount of phospholipids. Screen reagents, they always have low amounts of phospholipids. The reason behind that is when I limit the amount of phospholipids, coagulation factors have a limited space to do their job on. Because remember, coagulation factors need phospholipids to do their work. If they don't have that, they cannot do their work. Clotting is delayed. So when there are lupus antibodies, they will occupy a lot of the phospholipids quickly because the phospholipids are limited. So even a tiny amount of lupus anticoagulant will cause coagulation factors to miss these phospholipids, which means coagulation factors cannot do their job, which means the screening reagents are sensitive to even small amount of lupus anticoagulant antibodies, which is the purpose. I want to detect even small amounts. But remember a critical point. Screening reagents cannot confirm lupus because it can be that the patient has a prolongation with the screening reagent because they have heparin, they have warfarin, they have this, they have that, many inhibitors. Confirmatory reagents, they have very high amounts of phospholipids. Even if you have lupus anticoagulant, then the amount of phospholipids will still be enough for coagulation factors to do their job. This is a critical point because when confirmed reagents have a lot of phospholipids, enough for lupus antibodies and enough for coagulation factors. This means even if I have lupus, my confirmed reagent should give you a normal result. And this is the opposite of what customers think. Customers think that, oh, my confirmed reagent must be prolonged to say the patient is lupus positive. That's absolutely incorrect. Actually, if your confirmed reagent is prolonged, your result is inconclusive. You cannot say the patient has lupus. Okay? So when my screening is prolonged and my confirmed reagent is normal, that's a typical textbook lupus anticoagulant case. Okay? Because in the beginning, I said I have very little phospholipids. Even if there's a tiny amount of lupus, it will be detected. The next step to confirm I gave too much phospholipids. Even if there is lupus, I will still have enough. Okay? So when I do this, the only thing that really affects my results because it occupies phospholipids is lupus. Heparin does not interact with phospholipids. Antifactor antibodies do not interact with phospholipids. Warfarin does not interact with phospholipids. Factor deficiency does not care about phospholipids. Okay, so that is the point. Now, this is pretty much a summary of what I have just explained to you. The only difference between the screen and confirm is the phospholipid concentration. Screen has very little, confirm has a lot. And since lupus anticoagulant is the only inhibitor that we really know of that is phospholipid dependent, it relies on the amount of phospholipid in the sample or reagent. Then when a screen is prolonged and confirm is corrected, means the result is normal, then I say this patient is lupus positive. See, without confirm, you cannot tell the sample is lupus positive or lupus negative. You cannot rely on screening. Screening is not enough to diagnose a sample with lupus positive or negative. Now, in the middle, between screen step and confirm step, ISTH recommends that you run a mixing test. Now, what's the point of a mixing test? Mixing test in general, again, as I mentioned last time, tells you one of two things. The prolongation that you saw in your screening test. The screening test, by the way, here is PTTLA or DRVV screen, but also the same concept applies to PT or PTT. Mixing studies always have the same concept. They tell you two simple things. You have a factor deficiency or you have an inhibitor. That's what's causing the prolongation in your sample. So when I run a mixing test, it says what's causing the prolongation is a factor deficiency or an inhibitor. What's the inhibitor? It can be lupus, it can be antifactor antibodies, it can be anticoagulants like heparin, like DOAC, evaroxaban, apixaban, all of these things. Okay. So when I run the screening assay and it's prolonged, the prolongation can be because of factor deficiency. It can be because of inhibitors. I don't know. I have to jump to the next step. What's the next step? It's mixing. When I run mixing, mixing tells me the prolongation that you saw with the screening step is because of factor deficiency or a possible inhibitor. Okay. If it is because of factor deficiency, I stop my testing. I run factor assays because what's causing the prolongation in the screening step clearly is not an inhibitor, it's a factor deficiency. There is no point of continuing the testing. If the mixing studies say that you have an inhibitor, I have to continue with the confirm. Okay? Because the inhibitor can be lupus, can be heparin, I don't know. I have to continue with the confirm to confirm what is the type of the inhibitor. So this is again pretty much a summary of what I have mentioned. Okay? If the screening step is prolonged, in either the APTT pathway, that is PTTLA, or the DRVV pathway, that's the DRVV screen. If at least one of the two is prolonged, I have to continue testing. The one that is normal, for example, PTTLA is normal, the RVV screen is prolonged. PTTLA is normal, within range, I stop testing. There is no point. I continue with the RVV screen because it's a prolonged. Then I go to the mixing step. I run the mixing step. Mixing step says, no, what you have is an inhibitor, not a factor deficiency. I have to continue to the confirm step to check what is the inhibitor. Is it lupus or maybe something else? So if mixing step came back to within normal ranges, I say that what is causing the screen prolongation is factor deficiency. Mixing step is still prolonged. I say there's an inhibitor. I have to continue to confirmatory step. Confirmatory step became normal within range. I say that's it. That's a lupus case. Confirmatory step is prolonged. I say the result is inconclusive. I cannot continue my test. I cannot confirm that this is a lupus case. I have to check for something else, like anticoagulants, anti-factor antibodies, whatever it is, beyond our scope. This is an algorithm for lupus testing. This is for your reference. We will not explain all of this. If you want to share it with your customers, feel free. But this is pretty much a summary of lupus testing. And these are Stago cutoffs for the ratios, etc., etc. This is not a presentation about lupus testing, so we will skip this point. Now, what is our lupus offer? Remember, I said we have two pathways for lupus testing. One is APTT-based lupus testing. One is DRVV-based lupus testing. APTT-based lupus testing, first of all, and this is the most important point, is not an STA line. It's not an official Stago protocol on the compact or satellite or RMAX. Okay? So if the user wants to use it, they can use it, but they have the whole responsibility of this assays, performance verification, claims, etc., etc., because it's not an official Stago protocol. Okay? However, the DRVV, it's an official Stago protocol, just like PT, just like APTT, just like any other assay. For the APTT-based assays, we have PTTLA, which is the screening reagent. We have STACLOT-LA, which is the confirmatory reagent. So I need both. I cannot use PTTLA without STACLOT-LA. I cannot use STACLOT-LA without PTTLA. They are a system, okay? You cannot use one without the other. The same for DRVV. DRVV, as you can see, the name says, DRVV screen and DRVV confirm. So these are the reagents. You have them in the catalog for the reference numbers. And now you know the rest of the information. Now, what are our advantages? What is unique for us? What's our unique selling point for these products? First of all, our offer, APTT and DRVV, and for APTT Silica Activator, it's compliant with ISTH and CLSI recommendations for the composition of the lupus reagents, because ISTH clearly states that APTT should be a silica activator because it's the most sensitive to lupus presence. And the other type of assay should be DRVV. So this is point one. Point two, we are the only company in the market that provides lyophilized pooled normal plasma. PNP is pooled normal plasma. This is what you would use in your mixing studies. The only other provider provides it as frozen plasma. It should be kept at -70, which, as you can guess, is a huge difficulty for the customer. Third, the kit's performance is excellent, and this is not my claim. You can find a lot of studies on the internet, solid studies that show you that really the performance of PTTLA, STACLOT-LA, DRVV screen, DRVV confirm is an excellent performance. And as you can see, the arrow points to the right. If you want, of course, I'll share with you this presentation. Double click. This is a presentation, or this is an ISTH poster that was published just a few weeks ago. It will show you the performance of PTTLA and the STACLOT-LA against Siemens and Werfen reagents. You can see that they have superior performance, 100% accuracy. So this exactly also points to the fourth point. And the same, by the way, applies to DRVV. We have plenty of studies that supports their excellent performance. And finally, the fifth point, we are the only provider in the market that has fully automated lupus testing algorithm, and that is applicable on Coag Expert. Basically, in Coag Expert, we can program an algorithm. So we just tell Coag Expert through the LIS, run PTTLA and run the RVV screen. It will do all the rest of the testing for you up to the point where you get the result. That will reduce a lot of work from the user, and it will reduce all the errors that happen when the user does the testing by themselves. So this is a huge advantage, especially for labs with larger volumes of lupus testing. So before I conclude, do you have any questions about lupus? Because I understand that this is a bit of a complex topic and maybe a bit vague. So before I jump to factors, please let me know if you have any questions. So I take it no questions. All right, I will move on then. If you have any questions that come to mind later on, we can discuss them also by the end of the presentation, no issue. Now, for factor assays. The reason I mentioned factor assays, or I wanted to present factor assays, is that they might sound quite boring. You know, there is not that much of technicality behind it. There is not that much to discuss with the customer, not that much to promote. But actually, it's not really the case. There are a lot of intricate details that if you are aware of, you can really fight against competition quite well. Now, quick, somewhat technical introduction to factor assays. Now, factor assays are, as you know from the name, we use them to quantify the amount of the coagulation factors in the patient's blood. Okay? And they are basically modified PT or APTT assays. As you know, whenever you run a factor assay, you have to use the PT reagent or the APTT reagent. However, it's not a classic PT or APTT. There are modifications, two modifications really. So for the extrinsic and the common pathway factors, I will use them with the PT reagent. So any extrinsic or common pathway factor, that is 7, 10, 2, 5. These ones, I use them with PT. The others, the intrinsic pathway factors, I use them with APTT, that is 8, 9, 11, 12. All right? What's the reason? We don't care about the reason for now. What are the modifications from PT or PTT? For PT-PTT, we don't dilute the sample. Factor assays, we dilute the sample 1 to 10. I'll tell you later on why this is relevant. Plus, there is an extra step, which is the addition of factor deficient plasma. Why is that? We don't want to discuss this point. It gets a bit messy if it's a presentation, so there is no point here. Anyways, so we have the dilution modification and we have the addition of factor deficient plasma. As you know, whenever you want to run factor 8, for example, you have to have factor 8 deficient plasma to run the assay. Factor deficient plasma is simply a plasma that's collected from donors who are missing factor 8, or maybe these are normal donors, but we can later on remove factor 8 in the production facility. Okay, so factor deficient plasma is simply normal plasma that's missing one specific factor, and it's necessary for factor testing. Now, when do we need to run factor assays? What's the point? Why don't we just rely on PT-PTT? Now, of course, PT-PTT are essential, but PT-PTT, when they are prolonged, they do not tell you what factor is missing. Simple as that. Then why do we need to know what factor is missing? Simple, because not all factor deficiencies for patients will cause the same symptoms, and not all factor deficiencies will be treated the same way. So factor 8 deficiency is not treated in the same way, for example, as factor 2 deficiency or factor 5 deficiency or factor 12 deficiency. Because, for example, factor 12 deficiency, these patients are completely normal. They have no clinical symptoms, no bleeding whatsoever. They are completely normal, just like me and you. Okay, so it's important for us to know what is the missing factor and what is the level of the missing factor. For example, factor 8, if you have less than 1%, you are treated completely differently from someone who has, let's say, 60% or 50%, which is not really a deficiency. Okay. Now, what is our offering for our product lines for factors? It's tiny bit complicated. Okay, we have the STA deficient line, which is the older line of deficient plasma. The newer line is the STA immunodef. It's called immunodef because mostly we are relying on something called immunochromatography to remove the factors to generate the deficient plasma, but that's it. That doesn't really have any technical significance. Now, the STA deficient line covers all the factors. You have all of them, 7, 2, 5, etc. STA immunodef only has factor 2, factor 8, 9, 11, and 12. Factor 2 immunodef, however, can only be analyzed with neoplastin, STA neoplastin, which, as you know, is discontinued. Okay, so what should I go back to STA deficient 2? Yes, absolutely, no problem whatsoever. STA immunodiff 2 is not really superior in performance to STA deficient 2. So you can continue with STA deficient 2 because neoptimal is only validated with STA deficient 2. All right, both of them are available, no problem. But there is no point of buying immunodiff 2 because neoplastine is gone. Now, a couple of important points. STA immunodiff factor 8, 9, and 11 only work with CK-Prest. That is the official protocol. So factor 8, 9, 11 immunodiff only work with CK-Prest. Factor 12 is more flexible. It works with PTT Automate or CK-Prest in Stago official protocols, okay? So this is an important point. Be careful when you're starting with the new customers if you didn't work with factors before. This is really an important point to consider. Now, the less commonly known factor assays that Stago offers. There is something called a chromogenic factor 8. Now, maybe some of you did not hear of it before, and this is understandable because it's very rarely needed. It's needed for very rare cases or some patients who are very specific treatments. So this is chromogenic factor 8, as the name implies, not implies, really it's explicit there. Chromogenic factor 8 relies not on the clotting of the sample, but on changes in color. Okay, it's like the anti-TN assay, like the antithrombin assay. So it's a chromogenic assay, but it's an activity assay. So if there's an activity defect with factor 8 or a quantitative defect, we can detect both. And it's a kit produced by TicoAg, but we sell it under Stago. Just normally, you can order it without any issues. The reference number, as you can see. Okay, it's called TicoAg Trinichrome Factor 8 assay. When do I need it? Usually your customer, when they need it, they will ask for it, okay? But it's good to know that we offer this. The other type of kit is for factor 13. Now, factor 13 can never be an activity assay in our case, okay? Because it does not have any clotting activity. Factor 13 has no clotting activity, okay? Usually what's available in the market is an antigen assay. It's like D-dimer, basically. And the provider of the kit, we buy it actually from a third party, a company called Kamiya, a Japanese company. The kit is called KSA. The factor 13 kit itself, the part number is 1113. It has its own control and its own calibrator. So if someone asks you for factor 13 kit, you must buy its own QC with it and its own calibrator with it. Okay, it's a kit that does not share any reagents with our existing STA reagents. It's a standalone kit. You have to buy everything separately, okay? Now, that's apart from the commercial offer. There are some technicalities, but they're quite important for you to know how to answer the customer's queries. And you will see some of them are to our advantage, actually. Now, maybe you remember the point that we discussed over and over again about APTT reagents sensitivity to different things in the sample. We said over and over again, APTT reagents are sensitive to different things differently. For example, PTT Automate is far more sensitive to heparin than CK-Prest. PTT Automate is far more sensitive to lupus than CK-Prest. Okay, now why is this relevant? This is quite important, and you will see why in a second. And the same concept applies with all manufacturers. So Werfen, Sysmex, Siemens, Biolabo, Human, you name it, it exists. This is an APTT issue, it's not a manufacturer issue, okay? Now, this is pretty much a summary of the points that I used to make about APTT, but it's good to re-emphasize these points. Now, what are the differences? There are three main differences, between APTT reagents. The differences are the type and quantity of phospholipids in the reagent, the sensitivity towards heparin, and finally, the sensitivity towards factor levels. So these 3 points, okay? Now, CK-Prest, since it's used with factor 8 and factor 9, which are the most commonly requested, CK-Prest is almost insensitive to lupus, which is a great point for CK-Prest, as you will see soon, all right? And this is a great advantage for CK-Prest because most competitors, the reagents are moderately up to highly sensitive to lupus. CK-Prest is almost completely insensitive to lupus, which is very important because lupus, you don't want it to interfere with your factor assays. Otherwise, it will mess up your results, okay? And there is one tiny important point. I will remind you of this particular point in the last line at the end. Remember, I told you one of the two modifications in factor assays is that the patient sample is diluted 1 to 10, which means the amount of the inhibitor in the sample, if it exists, is reduced, which means its effect is also reduced. All right, I will come to explain why this point is important after a few slides. So these are slides just to give you a bit more details, okay? So as we said, APTT reagents, they have different sensitivities. So sensitivity to lupus is an important one, okay? And this is the reason. CRP can behave a little bit like lupus. So CRP tends to mess with PTT automate or lupus sensitive reagents, but that's not the case with CK-Prest. CK-Prest is safe from CRP. CRP, you know, is a marker of inflammation in the body. So if a patient has a strong case of inflammation, that might mess with their factor assays, but not if you are using CK-Prest. Now, the other points, as I said, that's sensitivity to heparin, sensitivity to factor levels, and that's important. Now, remember I told you there is this line. Sensitivity to inhibitors is just generally lessened since the sample is diluted. Now, if the patient, for example, has a high amount of lupus anticoagulant and you are using a lupus sensitive APTT reagent, then your factor assay result might be impacted. And actually, we have seen some of these cases in the field. So for example, warfarin usually promotes a lupus-sensitive APTT reagent as their main APTT reagent. Some cases with factors, we noticed that they are reporting low factor results for patients who had actually normal results with CK-Prest using our factor assays. That's specifically for factor 8 and 9. Okay, and that of course is not an ideal situation. And the issue behind that was mainly thought to be the lupus sensitivity because of the reagent of warfarin was lupus sensitive in that case. The same can apply to Siemens, by the way. Some cases we have seen them where CK-Prest gave normal good results and Siemens reagent, because it was sensitive to lupus, it gave a low factor amount, which is a wrong result, basically. You're saying the patient has hemophilia where the patient does not have hemophilia. Okay, so this is a very important point. It's a very important advantage for CK-Prest over the competitors' APTT reagents used in factor assays. All right, this point is for you to basically just read. These are extra points. Now, before I run factor assays, so we said we start with PT-PTT, but they are not very specific. All right, so we need then to know what is causing the prolongation in PT-PTT. Now the customer will ask you, okay, so every time my PT-PTT is prolonged, I will jump to factor assays. It will be extremely costly for me to do such a thing. The answer is no. Not every time PT, APTT are prolonged will jump to factor assays. Otherwise, the cost of testing will, skyrocket. It's not possible. There will be an intermediate step, which is the mixing study, which we just mentioned in lupus a bit ago. Mixing studies are quite useful because they tell you that the prolongation you are seeing with your whatever is the assay, PT, PTT, DRVV, lupus screening, mixing studies tell you that the prolongation that you are seeing is caused by a factor deficiency or is caused by an inhibitor. What's the inhibitor? I always have to investigate more to specify the inhibitor. But it tells you factor deficiency is the cause of prolongation or it's an inhibitor. How do I know it's what type of inhibitor? I have to investigate further. Okay. How do I know what factor is causing the factor deficiency? I have to run my factor assays. Okay. So what's special about the mixing study? How does it tell me this? Mixing studies are simple. You mix one volume of your sample with the same amount of pooled normal plasma. Pooled normal plasma, when you mix it with your sample, it basically supplies you with all the factors that you need to get a normal clotting time. Okay, so whenever I mix my sample with a pooled normal plasma, I am supposed to get a normal clotting time. Okay, so if I run the mixing study and I get a normal clotting time, means I was actually missing coagulation factors, because when I mix with the pooled normal plasma, I have added all the factors that I need. So my PT is prolonged. Then I run a PT mixing study. So I added all the factors which are missing. My PT result, PT mixing result became normal. I say, oh, okay, factors were missing. It's a factor deficiency case. Let's run factor 7, factor 2, 5, 10, etc. However, if you run the mixing study and the mixing study result is still prolonged, then I say, okay, I have fixed the factor deficiency issue that maybe was the case. But even I added the missing factors, I still have a prolonged clotting time, which means the issue is not really a factors issue. There is something else interfering with my clotting time. And in this case, we say there's an inhibitor. Okay, so that's how I differentiate using mixing studies between factor deficiencies and inhibitors. Again, how do I know what inhibitor is causing this prolongation? It's difficult to know. It can be an anticoagulant, it can be an antifactor antibody, it can be lupus, it can be very high levels of CRP with an APTT sensitive reagent. It's difficult to know exactly. You have to do further testing in this case. Okay, and this gets quite complicated quite fast. We will not go through this point, inhibitor specification. So this is pretty much the rest of what we have said. Okay, we run factor assays depending on the prolonged test. And if the mixing study said there's an inhibitor, then inhibitors here do not refer to the natural coagulation inhibitors. And this is a common confusion. Some people think that if my mixing study is prolonged, I have to run protein C, protein S, antithrombin, but these do not have any effect on your coagulation normally. Even if you have missing a protein C, even if you have missing a protein S, even if you have an issue with APCR, even if you have an issue with antithrombin, PT, APTT have absolutely nothing to do with these. And these are actually normal coagulation inhibitors. When we say inhibitors in the mixing studies, we are referring to some things which do not normally exist in your body. Lupus does not normally exist. It's a pathological state. Heparin is given as an injection. It's not a normal thing that exists. Antifactor antibodies are not something that normally exists. Okay, so when we say inhibitors, we are not referring to protein C, S, and antithrombin or cases of APCR. All right, we are referring to these guys: lupus, anticoagulants, antifactor antibodies, CRPs, some types of medications, etc. So when do I do, in this case, testing for the inhibitors? You might ask me, okay, why don't I always run lupus in this case? That depends. Okay, I will not go into much details, but just for you to know. So if I have a prolonged mixing study and I'm suspecting an inhibitor, when do I do lupus testing? I will do the lupus testing if the clinician requests that, or if lupus is the most likely. For example, the patient is a walk-in, they never took heparin, there is no way for them to have taken heparin. Okay, we ask them, did you take heparin? They say no. Do you take anticoagulants? They say no. Do you have a history of anticoagulant antibodies? Coagulation factor antibodies? They say never tested for that, etc., etc. All right, so that's a laboratory thing to decide. And there is this more information. I left that for you. Okay, I will not cover this point because I don't want to get too technical in this presentation. And I mentioned this point to you earlier on. Okay, then why don't I test for heparin and DOACs? Usually if the patient is taking heparin or DOAC, they would know. You would ask them. If the patient is in a coma, for example, we can ask the nurses, did you give them heparin? Did you give them any anticoagulants? They usually would know. Okay, so this depends on the cases. There is nothing that tells you if the mixing result was this much run anti-10A, if the result was this much run lupus. That's not the case. Okay, that's why I told you inhibitor testing can get complicated, and I don't want to get into the details of it. So there's a pathway that, or not a pathway, there is more details that will tell you what to test for in each case of mixing prolongation. All right, finally, antifactor antibodies, which are antibodies that target your coagulation factors. And when do I test for these? Basically, we test for these when we exclude anticoagulants, when we exclude lupus, when we exclude everything that can cause mixing study prolongation. Plus, the clinician is suspecting them because they have especially clinical presentation. Okay, we will not go deeper into this point. And again, this is a bit more details. One last point that I want to add. Maybe you have heard of something called Bethesda assay. What is the relevance of this Bethesda assay here? Bethesda assay is the way for us to test for anti-factor antibodies, which are one of the inhibitors for the mixing study. So whenever you hear Bethesda assay is used to detect the presence, for example, of anti-factor 8 antibodies, anti-factor 9 antibodies, anti-von Willebrand factor antibodies. There is a Bethesda assay for almost every factor that is out there. Okay, so Bethesda assay is not only for factor 8, Bethesda assay is for all factors. It just means an assay that is used to detect the presence of anti-factor antibodies. Done with the technical part. Now, what is our advantage here when it comes to factor assays? First of all, CK-Prest is the most relevant one. Why? Because again, CK-Prest is generally insensitive to the most common inhibitors that the lab might deal with factor assays, and that tends to be usually lupus presence or CRP presence, or sometimes certain types of medications that behave similar to lupus. Since CK-Prest is almost completely insensitive to lupus, okay, it's very unlikely to be affected by that. That's not the case with some competition reagents because they are sensitive to lupus, whereas CK-Prest is not. You might see cases where Siemens or Werfen will give low results, but will run a CK-Prest, the result is normal. The customer actually might be like, oh, how come your CK-Prest is normal where the patient is having deficiency? Actually, it's CK-Prest that's giving you the good result, not the other way around. Okay. Neoptimal is the same story. Neoptimal is quite insensitive to lupus, and in general, PT reagents are insensitive to lupus because they have very high amounts of phospholipids. Okay. Now, the other advantage that we have is for some of the factors for competitors, especially factor 8, they still have the need for something called the low curve. Low curve is another calibration curve other than your regular calibration curve that is used for low levels of factor 8 specifically. We used to have that with STA deficient 8 reagent, but this is no longer the case with immunodef. And as you can see, this is an issue that still exists with Siemens reagents on Sysmex analyzers. Now, another advantage that we have is that all the calibrations can be done at the same time and quickly. This is one of the major issues that Werfen has. Sysmex has it, but to a lesser extent. For Werfen, for example, you have to calibrate factors one at a time, and you cannot do anything. You have to leave the analyzer for almost an hour, completely paralyzed, just doing calibrations for factors. So this is not ideal. We don't have this issue, and you have to do them one by one on Werfen, for example. And finally, our reagents, the deficient reagents, are compliant with WHO and CLSI recommendations. The point here is, when you do Bethesda testing for factor 8 specifically, CLSI recommends that you have at least 50% of von Willebrand factor in your deficient 8 plasma. All right. Now, that's not the case with Werfen, for example. Werfen has this issue where von Willebrand factor levels are around 10% or less, which means their deficient plasma is not suitable for Bethesda testing according to CLSI. We don't have this issue. They have this issue. So if your customer wants to run Bethesda assay, our reagents are compliant, and we can prove that they are compliant according to CLSI. And this is quite relevant because Bethesda assays usually are quite a headache. So the customer wants to be as sure as possible that what they are doing is good. So you can raise this point that we are compliant according to CLSI, and we can prove it. Okay, so this is quite important. And we are done with the factor assay presentation. If you have any questions at this stage, please let me know. I will stop the recording at this point.